the idea, at least the way I look at it, is when I'm building a program or I'm building a plan, I'm not just providing exercises. I look at it as I'm providing a prescription for healing, right? It's a prescription of force at the end of the day is really what it is. You're using force to prescribe movement and to impact movement to create healing and improve movement patterns. So when doing so, there's a systematic process in the way you would apply that. No different than if you were taking a blood pressure medication, right? Like you're looking for a certain medication, you're looking for the appropriate dose and timing of when it's taking that. And I think that's something that I've spent a lot of time not only applying, but just be very curious over the years of how do you prescribe the appropriate dose to make the biggest impact on localized tissue, but also movement patterns, and then ultimately getting them back to where they want to be from a performance standpoint.
All right, AJ, welcome to the podcast.
Appreciate it.
Yeah, I'm excited to meet you. When you had messaged me, I looked at your bio and I was like, oh man, I'm going to learn something from this one. So you got 15
no pressure.
15 years as a PT. You've worked in private practice, you've worked in the military, and you've worked with professional sports. You've been with professional baseball for over 10 years.
Yep.
Talk me through, like, from grad school to now, how did all of that evolve?
Yeah, it's a great question. Obviously very loaded. I think coming out of grad school, my mindset was I wanted to, have my own practice. I think that was really kind of where my mindset was. But felt it was important just to get some reps, obviously, and just getting to see as many patients as possible. So I took the conventional route that most do coming out of school and worked in more of your traditional, conventional PT clinic, insurance-based, clinic. And, that was good for what it served. It teaches you a lot of things, especially when it comes to time management and working with high caseloads. And did that for about 3 years and just got to a point where, I was ready to start specializing. I have a history of, athletics myself, playing baseball through college. So just being around an environment of a team and, a collective group working towards a common goal was something that was always passionate for me. So I had the opportunity to go work with Army Special Operations in 2014. It was a program called Thor 3 where they were looking to develop a performance team for each group of special operations. So I had the opportunity to be a lead physical therapist with one of the groups there, which was great. Great opportunity, learned a ton. It was probably my first experience, like really working on a day-to-day basis with other subject matter experts, strength coaches, dietitians, mental performance coaches. So that was a really eye-opening experience for me coming out of the clinic where, you're really just kind of managing your own caseload, and maybe occasionally you can have a conversation with another clinician at the end of the day, but that's about it. Unfortunately, that was pretty short-lived due to some restrictions financially by the government where they had to kind of put a freeze on the program. And when they did that, they kind of started cutting back on some of the newer groups that were developed. And unfortunately, my group was part of that. So during the time of the freeze, I started looking for other things. And fortunately for me, the opportunity within professional baseball presented itself. So, was fortunate to get the job, get a position as just more of a treating physical therapist with the Pittsburgh Pirates, where I was seeing pretty much all of the subacute to long-term rehabs for the minor league system, and then all of the long-term rehabs for major league players. They would come down and see me at the facility. And it just kind of went from there, 10, 11 years later, I've been in a variety of different roles with the Pirates, where I started taking on a little bit more of leadership responsibility, started integrating, things like strength conditioning and nutrition and, skill development within, player programming, started overseeing a little bit more of that. In 2021 or end of 2020, I became the director of performance for the Pittsburgh Pirates. So I was over all of rehab and strength conditioning for the entire organization. So that's 7 or 8 different teams. Did that for 4 years. And really what it came down to was a life decision. Working in professional sports is a great opportunity. You learn a ton. There's a lot of pros to it. But there's sacrifice that comes along with that. And time is typically one of those major sacrifices that you have to give up. And, my family had dealt with me traveling on the road a ton for 10 years, and it was time to to shift gears and have a little bit more focus where I can be a little bit more present for the family. So we made a decision to make a change, and we moved. We were in Florida at our around our primary training facility for those 10 years or so when I was with the Pirates. And we made a decision to kind of change things up, and we moved out to Colorado. And at that point, I decided to shift roles with the Pirates. I knew it would be a little bit too challenging being that far away to kind of stay in my prior role. So I shifted to what is called a special assistant role within the Pirates organization. So what I do for the Pirates now, it's kind of twofold. One, I still work as an advisor for rehab and strength conditioning. We get complex cases, walk through those things, discussions around changes in philosophy of programming, I'm involved with those conversations as well. And also just kind of being a guide and a mentor for a lot of the staff, because I was, doing those same things over the last 4 or 5 years for a lot of the staff that are there. And then the other piece of it is I've gotten more involved in the scouting process. So a lot of movement and athlete analysis within the scouting process. That started more on the amateur side, the players are more domestically in the U.S. A couple of years ago, I kind of took on that project while I was in that director role. And then that has kind of grown and evolved to where we're now looking to grow that into pro evaluation and also international scouting. So that's the one bucket in regards to staying busy and kind of staying connected with the pro baseball setting. And then once we moved out to Colorado, I made a decision that I wanted to start getting a little bit more interaction locally with working with patients again. In those leadership roles, you don't do as much of that. I still had time to work with athletes at times, but it wasn't necessarily my primary job at that point. And you miss it. I think as a clinician, you're always looking to find ways to impact people and help people, and you enjoy the programming and you enjoy the treatment aspect of it. And that was something that I was looking to get back into. So once we moved out here this year, it's kind of still in the early phases, but starting more of a local sports rehab and performance business in South Denver area.
Okay. Why'd you pick Colorado?
I think it was more of just a lifestyle. It's very, very active,
Yeah.
collectively. I think my wife and I found that anytime we would do vacations and trips, we would always find ourselves out in the mountains, hiking and mountain biking and, those types of things. So it was kind of just a draw of, what are the things that we like to do when we're not working and stay involved in. And I think that was really the primary draw. So the ability just to be able to get out and get into the mountains and be active and be, around a lot of people in a community that is relatively active in general. This is kind of what we've experienced with the time that we've been out here. So far it's been good.
Nice. Your kids like it?
Yeah, it's been an adjustment. Obviously, we only have one young daughter, 4 years old, so she's starting to just still get into the mix with some hiking, and we got her skiing a little bit this year for the first
Nice.
time, and that type of stuff. So I think that was a piece that weighed into it too. What do we want her to have access to growing up, and it was just like I said, it's kind of worked out. It seemed to be the location that we wanted to go to, and so far we've only been here a couple months, but it's been good since we've been here.
Okay. So how long after you moved did you start thinking about working with PT Biz?
So I had looked into PT Biz a few years prior, even while I was still in my other role, because when you start making life decisions, it's not something that maybe some people, but I'm more of a planner.
Yeah.
It was something I kind of seen coming for a year or so. It was more of a timing of when, not if. So I've spoke with some of the representatives at PT Biz a year or two prior, just to learn a little bit more about their process and their model and what they were looking at in regards to building up more of a cash-based type practice. And I think for me, after especially working 12 plus years in a setting where you have a lot of autonomy, right? Well, like with the military and in baseball, you have a lot of the ability to really flex your muscles as a clinician and do what you think is the best to get the people back. The idea of going back into your more traditional, conventional PT setting where you're a little bit more limited and the ceiling's lower in regards to what you can do due to insurances. It just wasn't a setting that seemed to fit for what I wanted to do at this point in my career. There's a big focus for me of just wanting to maximize my experience and skill set to get people better as fast as possible. And I felt that going that route would allow that, and would I would be able to impact people in a much larger rate by going more of that cash based route. And the PT Biz format, or kind of playbook, seemed to fit really well with kind of the
Yeah.
thought process I had going into it. So
Well, I would imagine that working with the Army and then working with pro baseball, their main I'm sure like the main focus for both of them is performance. We need to get
sure,
these athletes performing at a high level again or up to speed. So giving you the freedom to basically meet that, get them there as quickly as you can has got to be a little addicting because it's
sure,
like, you don't have to think about, well, will insurance reimburse for this, or how many minutes did I actually do that for? And
right,
there's all those other things that just go out the window, and you can just win and succeed and do great things and excel. And then, yeah, the idea of shifting from that extreme to basically the 180 degrees to another extreme where your care is dictated by codes and all different on a lot of other stuff that doesn't have anything to do with getting the patient better. I can imagine that is like a dismal thought.
sure. Yeah, and I didn't really realize the impact of it as a clinician until obviously I worked in a different setting.
Yeah.
Your point is very valid, as there is a push on performance. It's not just the ability to rehab a very isolated or localized injury. It's how can we get this person back to the level of performance, or even exceed the level of performance that they were at prior to the injury. And there's a baked in piece of higher level of pressure at times, because
Yeah.
there's a high push to get people back as fast as possible in both of those settings.
Yeah. Yeah.
And it's not like as a clinician that you're ever taking your time necessarily. You're always focused on getting people back faster. But I think the luxury of that setting was that pressure being a little higher. So you really had to think quickly and really maximize the time that you had with the patient and figure out which ways, what are the things that do get people back a little bit faster. How can I build this into their program while they're still having to execute their other parts of their job. That was probably a little bit more difficult with the military versus baseball, because with baseball, if there's an injury, you're typically all right. You're just shut down, and your job is to heal and get better for that amount of time. And that wasn't necessarily the case with the military. A lot of times there was a lot of expectations to still do a lot of their
Mm-hmm.
typical duties, all while rehabbing, which is what a lot of people, more in the quote unquote real world have to deal with, right? Like they're trying to get over injuries all while still working and
Yeah.
working their full-time job and taking care of their families and trying to do the activities they want to do. So,
Well, I think the concept of trying to be as efficient as possible is, I think, maybe what stands out to me is one of the key points you made, because that is not necessarily important if you're billing insurance. I mean, it can
right,
be. It's just not. You you have to think about things differently, and it's more about what alphanumeric codes that you're going to have to run. And I think that maybe one of the hardest things for me in this whole process is, how do I communicate the benefit of stepping outside of the insurance model to someone who has good insurance? Why would they choose people like us when they could then there's 10 providers down the street who take their insurance? And I think your point, for anyone who's thinking about that or asking themselves that question, why would I do that? I think it's valid. It's because you as a provider, you don't have to think about anything other than meeting their timelines and taking care of them. So they want to be able to do X, Y, and Z to a certain capacity in a certain amount of time. And the obstacles throughout that process are job, sport, work. So you get to look at all of those things and assess where they are. And then you can just make decisions with them on the best way to get there. And you don't have to think about all of that other stuff. And I feel like when I get patients who are, have been through other pipelines and they haven't gotten the results that they want, that's kind of what ends up happening is, well, the PT or the doctor, whoever it is, they want to think about you. I don't
Right.
want to say that anyone's trying to do a bad job, but they also have to first meet all these other criteria. And if helping you to the maximum interferes with any of those other essential things, which usually are set by the insurance companies, then you don't get that care. And for some people, depending on your coverage, it's like, if your insurance doesn't kick in until you hit your deductible, and you're not going to hit your deductible, you're paying the same price. For a lot of people, you're basically paying the price for like individual cash based care, but you're getting the cookie cutter program that they would give to any patient that walks through. And again, I don't want to blame the individual providers, because I've worked in those scenarios too, and you don't really have a choice.
Right.
You have to follow certain things, and you're an employee, and there's a structure to it. So
Yeah, I think that setting. I mean, and to your point, it's rarely ever. You can't say always, right? But it's rarely ever the clinician. It's the structure in which that you're working in there, and it does kind of force feed your ability to treat a certain way or approach each case a certain way. I think looking back on it now, some of the advantages of working through, or, if I was a patient going to more of a cash-based open facility in that regard would be, you, as a clinician in that setting, let's say you've only worked in that setting. Some of the limitations that you end up having is, one, volume runs into an issue, right? Like where you're potentially having to manage multiple patients at once. So it's really, really challenging to really give somebody the care they need if you're managing 3 or 4 people within a given hour. You do end up going, like you said, you end up having to give them a sheet of paper sometimes, and you're hoping that you can get 10 minutes of your hands on them, but you're also limited to only 10 minutes of their hands, because that's what's potentially billed for, and that's what you can get paid for, or the clinic gets paid for, and you're stuck within that construct, right? I think the other really eye-opening thing to me, and I noticed this obviously in my own progression out of that setting, but also as I hired clinicians out of that setting while I was in baseball, is one of the biggest limiting factors, in my opinion, in regards to getting people back to where they need to from a pure performance standpoint, is if you've only worked in the clinic, you've never really worked backwards from what the end result is. And because you've never taken somebody from the beginning of the injury to their end result. Typically, and at least on the PT side, if you work in a clinic, by the time they're relatively out of pain and you've met a few goals, insurance stops paying, so they're gone. They're not necessarily ready for performance based off the goals that they want to get back to in life. Typically,
yeah,
there's some type of bridging time frame. So you're capped in the ability to really see the bigger picture of what they're actually working towards, and how to program somebody up to that point of, whether it's competition, whether it's, just being able to do something within their current job, or do something at their home. It's very rare to have the ability to treat somebody all the way through that process. And I think that if you've had the reps of treating up to that point of really getting somebody back to their full potential, it impacts how you approach the earlier phases of their rehab process. And because you can see the collective picture, and you potentially may start doing some things earlier, or wait on certain things, or be a little bit more aggressive in certain areas when you really know what the end result is. I think that's one thing, at least in my experience, I learned a lot from working with, like athletic trainers, is because that's a lot of what they do when they're working with athletes in season, is they can only focus on the end result, because ultimately their job is to get them back on the field. A lot of times the injuries are more acute and subacute, but
mm-hmm.
that's still the focus,
Right.
whereas in the traditional clinic, you just don't get those reps. Those are probably the biggest gap, that when I would mentor my physical therapist that I would hire into baseball from the clinic, that was probably the largest gap to fill. Was, okay, how do I approach this once their range of motion is back and they're relatively out of pain? Now what? Because typically once they get there, their patients are discharged, and
Yeah.
they get the next person that comes in. So I think that's the advantage a lot of times with more of a, performance based clinic that is, out of network, cash based, however you want to put it, is you're potentially getting a lot more one-on-one time with your clinician, but you also have the ability to work as a team, you and the patient, to get them fully back to performance,
Yeah.
and and not being restricted by any other outside constraints that may be hindering your ability to get there.
I think that shift, working with the patient as a teammate rather than you being like the overlord that says, this is what you're doing. This is the prescription that comes from my clinic,
Right.
where you can kind of get off that pedestal and be like, what do you want? How quickly, you know what I mean? And you can get that feedback. Well, you didn't, so that like the idea of a non-compliant patient just kind of goes away because, okay, so you didn't do everything you were supposed to do. Why? Did you not understand? Did you not like the exercise? Is the dosage wrong? You can ask all those questions and you can kind of refine that and shift accordingly, or completely tear up the program and change it so that they become compliant. And then the opposite of that is being stuck within a rigid system where if the patient, like I have a system and I have to make every patient fit that regardless,
Sure.
or I just run out there and if they got 12 visits, I just run them out and we do the best we can. And then the opposite of that is what I think what you're describing is, well, I can change everything to meet your goals. I have a ACL patient right now, and it was cool because he's a collegiate baseball player trying to get back for preseason. And after surgery, I got to meet with him and his surgeon, and we just all got to discuss, like, this is the timeline. It's an accelerated timeline. What do you think? And we all got to have our input. So our team is now a team of 3,
Right.
where the surgeon obviously has a lot of buy-in, but I wanted to make sure, look at the program, look at the timeline. If he meets these specific things by early, we're going to push beyond that. Are you okay with that? And then, the surgeon got to give his thoughts and his insights and saying, well, these are hard timelines, that you can't mess with. But other than that, we can kind of move around. And the patient gets to sit there and listen to that whole discussion and then weigh in. And to your point, now we've got this team effort, and the buy-in from the patient side is huge,
Right.
because he's got basically 2 doctors shaking hands being like, let's get this guy back to sport when he wants to be back to sport. And then he knows his role. So there'll be, if I call him in between sessions, like, did you do your rehab today? If he didn't, I can, hey man, this is what you wanted.
Right.
I'm not telling you to do anything. I'm just telling you, this is what you wanted. This is your goal. And but I never have to have that conversation because he's so bought in and he understands the process. And that's something, working in a different setting, that I never had the opportunity. One, I would never have the time to be able to block my schedule to go to a visit, what I mean,
Right.
with a patient and a surgeon. Just wasn't in the cards, but I got to take a morning off because I control my schedule and go have that
Sure.
conversation. So I think it's probably something you are now accustomed to working, with in like a setting that you described in baseball, because all the providers, I'm assuming you guys would meet regularly about and talk about these things.
100%. Yeah. I mean,
Yeah.
it's like I said, been fortunate with, I mean, it's now become second nature because I've done it for so long, and attempting to make a similar approach within, my own business,
Yeah.
of everything that is done is more of a patient-centered approach, right? Like the
Yeah.
patient is part of the plan. And then you're finding the subject matter experts around that could ultimately make the biggest impact in getting them back to where they need to be.
Yeah.
In the sports setting, you're very lucky. You're fortunate. You have, a variety of subject matter experts that are all weighing in on what you know, how to get to the outcome that's desired. Whether it's strength coaches, physicians, nutritionists, mental performance coaches, athletic trainers. In that setting, if you're really looking at a longer term rehab process, the physical therapist is kind of the quarterback of the plan, but
Mm-hmm.
you're still taking in all of that information because all of those people are implemented into the process, right? Like
Yeah.
in that setting, I may be working with an athlete, but But then I don't run and go do all of their strength conditioning work. They work with the rehab strength conditioning coach. They have a plan with the nutritionist, and they have the plan with the mental performance coach. And then you have your consistent check-ins with the physician. So like everybody's bought in, and you're having, basically daily conversations in regards to how's the plan going? Are we meeting the short-term objectives that we want to get to hit the milestones they need to get back on the field? And do we need to, shift or change the outcome for the end result
Yeah.
of getting them back on the field? So to your point, like the patient has to be involved. Like it creates buy-in. It creates more proactive of getting back to where they want to be. And it, like you said, it doesn't seem like somebody's just kind of shouting down at them to do this. We are part of the process as clinicians. It's, especially if you're only able to see somebody a few hours a week at best, um, there's a lot of need for the patient to buy in, right? Because there's a lot of other time where things could be done and impacting tissue or impacting the rehab process, and that may be done on their own time, right?
Mm-hmm.
So, finding a solution that works for them based off of the constraints they have for time, whether it's family or job, coupled with their program, and then what is their end result, and you find the best way to get that done, because the consistency piece is probably the biggest thing out of anything. You can have the best program in the world, but if you're not able to create some consistency around doing it, it's not really going to get the results that you want.
Yeah, but I bet you've picked up a bunch of skills working in that environment, or a bunch of knowledge at least, working with those other
Sure.
providers.
Sure. I mean, I'm definitely a much better clinician now than I would have been if I
Yeah.
would have never had the opportunity to work with all of those different types of providers, because, they just have a different lens. They're seeing it from a different lens, and they have a different scope. And yeah, I learned a ton. I mean, not only from the other providers, but from the other, skill development coaches, different baseball coaches. When I was with the military, working with some of the, higher level officers of their expectations and demands, and going out on the field and watching what it looks like with some of the work they're doing.
Yeah.
That has definitely impacted me as a clinician in general, to see a larger picture of what the plan could look like,
Mm-hmm.
to get somebody back to the results they want to get to.
Is there any specific profession that had the most impact on you?
That's a good question. I would say, like, if I'm specifically, I would probably have to say the strength conditioning side if I was
Mm-hmm.
really going to narrow it down to one.
Yeah.
I think it's easy to go, like a 1B would be the skill development coaches, like specific if we're talking about baseball, obviously, really understanding the movements
Yeah.
and what the internal, the hidden pieces within the game that you have to consider when it comes to building out a program. I think that's one piece that maybe is not understood as well as a clinician in like a professional setting. You're not just building out their rehab exercises for an hour, you're building out their entire workday. So you're building out 4 and 5 hours of what they may be doing that day, and considering all of the different work they're doing within that process. So you have to really get an understanding of what are they actually doing on the field and what are the coaches saying. But I would say, to your original question, strength conditioning has likely had the largest impact. Part of that is I'm biased, because even getting into baseball or getting into physical therapy, I was already interested in strength conditioning
Yeah.
myself. But the ability to impact my overall programming and thought process around how do I impact strength qualities, how do I impact tissue quality, and how do I continue to build up and transfer some of those qualities into skill of movement. By far, the strength conditioning side's probably had the largest impact.
What I'm visualizing right now is, so you're talking about the limitations as a clinician, because usually we're just like, we get back to like activities of daily living and
Right.
decreasing pain, but then there's this huge gap between where our skill set tends to leave off and then sport performance. And then when you think about strength and conditioning, that that influence fills that gap, you
Sure.
know? And I think if you're looking at a provider who has at least a basic understanding of the whole process, at least even if you get in a situation where you're like, I don't know what the next step is, you would know that there's a next step, one, that you're
Sure.
not done, and the resources and where to go, and you'd at least have an idea. And I feel like that maybe that's where I see a lot of problems when people come in and I'm like, okay, well, what have you done? Why don't you think it worked? And when they're describing it, it's like, oh, they stopped really short, and then either they ran out of time or didn't know what to do, but they acted like it was almost like gaslighting. Like, nope, you're good. Like, it's all good. Like, they said I was good.
Right.
And it's like, well, yeah, by certain metrics, you probably were fine. But, you know, I mean, would a Major League Baseball program really care if their athlete, you know, couldn't, like, was bad at, you release them and they're bad at sport? And you're like, yeah, their range of motion's symmetrical though. You know what I
Right.
mean? Like, I strength tested them and they're good and they're 0 out of 10 pain with ADLs. So, you know, like, you know what I'm saying? Like, the,
Sure.
for military or sports or just active people who want more than that, a lot of the metrics that we look at are only indications that someone's moving along in the process, but are they actually better at the activity that they care about? Like, it
Correct.
has that activity improved, has sport improved? You know, it's like, and another example would be like, if you took a football player in the off season and you doubled his bench press and doubled his back squat, but he got slower and he was missing tackles, and the coach is like, he's a terrible football player. You're like, yeah, but he's super strong now. Like, well, that's not the
Right.
sport. Like, you took a segment of something that would maybe translate to sport performance and you went crazy on it. And I feel like clinically, a lot of clinicians have that problem where we're like, I don't know, I do range of motion and strength testing and I do all these basic things. And if everything's good, then they must be good. And active
Sure.
people with real goals, they need a lot more than that. And
Sure. And I think it's a completely valid point. And I think part of that issue comes back to what we referred to earlier is not really understanding the process of getting back to full performance and
yeah,
not really having the experience of doing that because you kind of get handcuffed in a way of like, all right, if I have a very limited time with this person and I have to show progress. So the easiest way to do that is these random, range of motion measurements or some type of strength measurement, manual muscle testing. Not that those aren't good to do. Obviously, you want to have some checkpoints along your process, but it's rarely ever like really tied to what the ultimate goal is because you may not get the opportunity to get them there. Is because as soon as they start to show some progress, then they're kind of moved out of the clinic and you're working with the next person. So
yeah,
it really comes back to understanding, and this isn't applied just to like professional college athletics. It can apply to anybody who's proactive in their life and they have goals they're trying to get to. Is you started that end result and you work backwards in regards to building the program, and that by itself, if you understand the movements and the physical qualities that are required to get to that point, that sets up your platform for your programming and kind of set your goals for you. But if you
yeah.
don't really have a good feel for understanding what are the demands of the movement that I'm asking and required to do, it's very challenging. You get caught in that trap that you're referring to. It's like, well, I don't understand the movement, so I'm just going to say, well, if they get to 140 degrees of flexion in their shoulder, they're fine. And that's not necessarily the case. It can help. It could be a step forward towards that process, but clearly that's not going to be the answer to getting them back to their performance, depending on whatever their ultimate goals are.
So then, based on all of your past experience, what would you say to like a prospective patient about the benefit of working for you? Like, if you could summarize why, if someone's like, well, I have a lot of options, why would I pick AJ?
Sure. Yeah, I think you know relationships are a big thing, right? Like you have to be able to build a relationship and really have an understanding of the people that you're working with. And I mean, everybody's a little bit different there. You got to have a little bit of variety. But I think in general, the biggest separator for me, and we've touched on a lot of the highlights of it, of having the experience of working really backwards from what the ultimate performance goal is, and having the experience of doing it for a lot of people, a lot of athletes, a lot, not just athletes, but those in the military and those outside of it, and being able to really apply the concepts of what are the concepts of getting somebody back to either the performance level they were at or even higher in the shortest amount of time possible, and then minimize the reduction of re-injury with continued programming. That's an area where I've had a lot of experience. I've been fortunate to learn from a lot of people in that process, learn from mistakes, and
Yeah.
fine tune your process around that. And there's just not a lot of clinicians that's potentially had the opportunity to do those things. And it's something that I feel like I've really boiled down to the ability to apply to a lot of different types of patients, not just professional athletes.
Yeah.
You can, if you have goals in mind, and a lot of times you're having to help people realize what those ultimate goals are. They may come to you and just say, "Oh, I have pain." It's like, well, let's dive a little bit deeper into, you have the pain, but what's it ultimately holding you back from doing? And then once you establish what that is, then you can build that program to work backwards from there. And obviously there's a lot of, variation and variety of skills and treatment, processes and all those things. And, I've had, a ton of exposure to a lot of those things, but I think the real separator is the idea, at least the way I look at it, is when I'm building a program or I'm building a plan, I'm not just providing exercises. I look at it as I'm providing a prescription for healing, right? It's a prescription of force at the end of the day is really what it is. You're using force to prescribe movement and to impact movement to create healing and improve movement patterns.
Yeah.
So when doing so, there's a systematic process in the way you would apply that. No different than if you were taking a blood pressure medication, right? Like you're looking for a certain medication, you're looking for the appropriate dose and timing of when of taking that. And I think that's something that I've spent a lot of time not only applying, but just be very curious over the years of how do you prescribe the appropriate dose to make the biggest impact on localized tissue, but also movement patterns, and then ultimately getting them back to where they want to be from a performance standpoint.
What's your favorite thing to work with? Do you have a specific injury or body part or anything you're like when that patient calls up or walks in, you're like, yes.
Yeah, that's a good question. There's not a whole lot that I don't, at least within like the orthopedic and sports medicine realm, there's not a whole lot that I don't really, and I always enjoy the puzzle because no two injuries are the same, probably through my career, I've always been more of I've always been kind of the go-to person for shoulder injuries, I feel like.
Mm-hmm.
I've had a ton of elbow injuries I've worked with in baseball, but that's obviously more specific to
Yeah.
throwing injuries. But I would say in general, if I really look back at collectively the career, I've always kind of been pulled towards shoulder injuries. And I enjoy working with shoulder injuries because they can be complex. There's rarely a very straightforward shoulder injury,
Yeah.
whether it's due to, the different things that the person's trying to get back to or their limitations in life and all those different things. So shoulders are always a puzzle, a challenging puzzle to work with, and fun, and it's something that I've just had
Yeah.
a lot of time and experience working with just because of the settings that I've worked in up to this point.
When you're working with non-professional athletes and
Yep.
non-military and people have shoulder pain, like you said, there's so many things that go into having shoulder issues. Are there any basic fundamentals that you see with the general population for people who struggle with shoulder issues that you're like, oh man, I mean, like when people come in, you just notice these are common trends with the average
Sure.
population?
Well, the interesting part about that is I mean, if you separate like a very acute, sports type injury, like
Mm-hmm.
the the body itself is still the same, right?
Yep.
Like the athletes are still people. Like you still treat them. You see a lot of the very similar injuries or presentations a lot of times. But I would probably say the most common is people don't have the ability to rotate the shoulder. Like the actual shoulder joint itself doesn't rotate very well,
Mm-hmm.
whether it's forward or back. And not having the ability to rotate the shoulder limits pretty much all of the other motions of the shoulder. Overhead flexion always gets like the big everybody's always worried and concerned about the overhead flexion where that being limited because a lot of times there's pain there. But a lot of times there's linked to the inability to rotate at the shoulder that also contributes to the fact of not being able to reach overhead. So I think that's a very common one where they just don't have that, whether it's, structurally limited and there's tightness in the shoulder or capsular tightness or lack of control of the motion where they just don't
Mm-hmm.
have the ability to rotate without some type of large compensation patterns. I think that's definitely one of them. I think another is you could potentially link it to just how well the scapula itself moves, but I think just posture becomes a big piece and the ability to get more upright and not be in more of a slouch position. Tightness, you can argue whether that's true thoracic extension or you're getting it from the low back or whatever it is, but just the ability to be in that good position to where it doesn't limit your ability to reach and get into that overhead flexion. And I think society, the way it's built, we spend a lot of time sitting in chairs and in front of computers now. And, a lot of people in most of their jobs, at the end of the day, gravity ends up winning, right? It just kind of starts pulling you and
Yeah.
slouching you forward over time. And if we're not doing enough to combat that, to maintain good upright position, it just doesn't put the shoulder in the best position for success. And that's the slow drip over time that ends up leading to stuff where it's like, oh, I never had a shoulder problem before, and I woke up and my shoulder hurts, and now it won't go away. A lot of times, it's some of those other contributing factors that led to it, and I think that ties into the third piece is most people don't really pay attention to keeping their shoulder healthy until there's a problem, right? Like if you see somebody in the gym doing some type of exercise, like a rotator cuff exercise, it's typically because either A, they're injured or they've been injured before, so they have an idea of what to do. But we're typically very reactive in regards to keeping our shoulders healthy, whether it's how well it moves or the strength around the shoulder. So I think those three areas end up leading to a lot of the contributing factors of why people deal with nagging shoulder injuries or stuff that kind of built up chronically over time.
It seems like one of the most frustrating things for people who have shoulder pain is that, and I know this from experience because I've had a lot of shoulder issues, is like it's a cross sectional area. So if you have a shoulder that's bothering you, everything in life is terrible.
Yeah,
You know what I mean? Putting on clothes is terrible. Driving a car, like just moving your neck or
sleep.
just sleep. Yeah, like literally, I feel like shoulders and low backs, you just and necks as well. So you can't like if those areas are just not functioning well and painful and stiff, quality of life just plummets. The interesting thing though is I feel like it's a knee jerk reaction for a lot of clinicians, and I'm not even going to say that it's a specific type of clinician. I think it's just across the board to recommend rest. Oh, it
Yeah,
hurts. We'll stop doing the stuff that hurts and rest it. And while I agree that in the short term, maybe 24 or 48 hours, something like that, it's not a bad advice. Like, let's take a beat and calm things down. That short recommendation for rest turns into a decade pretty quickly. And
sure.
now, like, you haven't used it, you're deconditioned. The injury itself, like, if there was tissue damage, it surely healed, but it probably didn't heal well. And you've
Right.
lost all that capacity, and now you don't have the range of motion. So even if you stretch and regain that range of motion, you're not used to it, so that hurts, and you're weak in those positions. So I feel like if you can get someone quickly, they're like, I don't know what's going on. I've had shoulder pain for a week. I don't want this to turn into a chronic issue. That tends to be a lot easier than someone who has literally the same presentation, but it's like, I don't know, it's been nagging me for a decade.
Sure.
Do you find
Well,
that working with a lot of shoulders that there's a big difference in the way people respond based on how long they've just let something linger?
100% I would agree with that. I mean, because like we talked about, it's when you've had something for a long time and it starts to become more chronic. One of the amazing things about the human body is its ability to compensate. Like you ultimately will find a way to get the job accomplished of what you're trying to do, but you typically start trying to find different types of movement solutions to get the job done that may not necessarily be advantageous for the shoulder, let's say. And then you start developing these big compensations. Things start to get tight, things start to get weak. And over time, it just snowballs and snowballs and snowballs to where you are so limited, whether it's due to strength or just the ability to move the shoulder from a movement standpoint, that you've learned this other pattern of movement now, and that kind of becomes your go-to when it's not the best for the shoulder, and it just continues to build from there. So yeah, the more acute injuries typically are the cases where maybe you do have to take a little bit of rest depending on the situation. But it's probably going to be, at least in my opinion, some type of active rest where we're immediately trying to restore losses in motion or losses in movement quality, because it happens quick. If you don't move the arm for a while, it, even within a few days or a week, you start to notice a difference. I think ask anybody who's had their arm in a sling for any extended period of time. Coming out of it, you just do not feel like you can move the shoulder very well. I mean, I think I've spoke with a couple of different surgeons who, they all had the kind of the same idea. It's like if we didn't have to put an arm in a sling, we would never do it
Hmm.
because of the atrophy and the weakness that comes and the tissue breakdown that comes from just keeping the arm still for that long. But obviously, it's a necessary need because you have to let the structures heal that they maybe have done a procedure on. And somebody who's had a cast on, take that cast off, they've lost muscle, they've lost the comfort of moving around. So, you know, inactivity, to your initial point, is one of the probably worst things that you can do in regards to truly restoring probably any part of the body, but especially the shoulder, because it needs to move so much. There's so
Mm-hmm.
much degrees of freedom that the shoulder provides with movement, that if you start to lose any of that movement, it really impacts all the other ranges of motion, or potentially puts more stress on the tissue in the other areas that you're not really using anymore.
Yeah.
So yeah, that's a tough one. And with chronic cases, yeah, you try to get it going as quickly as possible. Like that's really the goal, is to get it moving. But there are cases that you
Yeah.
know calming things down, or at least minimizing and altering movements, in those acute situations. Like, yeah, if pressing something heavy over your head bothered you yesterday, maybe let's not do that for a couple of days and let's reassess.
Yeah.
But let's keep the shoulder moving, and let's see where you're limited potentially overhead, and let's take advantage of the available motion that you have that's not painful, and do a ton of work in that space, because over time you will start to regain that motion, because you're basically teaching the brain that, hey, I'm not creating more damage by moving through here. So you start to break down some of the spasming that may be happening around the shoulder, limiting the motion, trying to slow down that snowball effect as much as possible.
Yeah. How do you address, or how do you like to address fear of movement? Because people who haven't moved in a long time, generally pain freaks them out. And I think, that people hear what they hear. And I feel like the recommendations from healthcare providers are always well intentioned, but we have to be really cautious about the words that we use in the descriptions, because some people will not move a joint very much for a couple decades because
Mm-hmm.
they heard certain words and now they're afraid of it. And I find this particularly hard with tendon problems. And I imagine you see a lot of tendon problems in the shoulder where, someone's like, they get diagnosed with tendonitis and it's chronic, and it's like the recommendations were rest, ice, anti-inflammatories. And it's like, yeah, if you don't tug on a tendon, it's going to feel better for sure. And then they're
Right.
just like, well, so they go through this period of rest, ice, anti-inflammatories, it feels better. Then they start moving again and it hurts again. So then they think, oh no, I'm hurting, the tendon's getting inflamed again, I'm hurting it again. So then there's this cycle of rest, pain, and this goes on for years and years. And then if they come in to see you and you explain to them, okay, the rehab process is going to be uncomfortable. There's going to be
Right.
a certain level of discomfort that you're going to have to accept. They may hear that and say, okay, I acknowledge that, but the actual process of doing it, that fear of movement, because it's been so long, and
Yeah.
not only has the pain been there for so long, but now they're weak, they lack confidence. They still have those words, whatever was said to them, in the back of their head, and you're a new provider, so they may not know you very well. So maybe the person who gave them that information before, they have a better relationship with. What is your process? And I don't maybe want to be able to describe this because it's so broad, but how do you like to address people when they're terrified of movement, and movement is the answer to the solution to what they want?
Sure. Great question. And we see it, we see it in the clinics all the time, whether it's shoulder or other parts of the body. But specific to the shoulder, my approach would be, if there's heavy levels of fear involved, you have to create some level of confidence that progress can be made. And typically the best way of doing that is taking advantage of the available range that's relatively pain-free. I mean, as you mentioned, if you're really pushing the boundaries of trying to get somebody back and being aggressive with their plan, there may be certain levels of discomfort that you work through, and you try to minimize that and keep that as low as possible. But understanding that pain is also, it's information, it's signal. It tells us things. It tells us when we're potentially doing too much, not enough, and just painting pain by itself as a descriptor can be tough too, because timing of discomfort, when are you getting it, all those things tell us a lot of information in regards to how the tissue responds. So my initial approach after explaining some of those concepts would be to do as much movement through available comfortable range as possible. And as they build some confidence there, they will have the ability or more willingness to start pushing the boundary a little bit into some of those other areas that may be a little bit more uncomfortable. And you're flirting with that line potentially that
Yeah.
may cause discomfort. Maybe it's a combination of doing some manual treatment where there's some manual facilitation into the movements where my hands are on them and helping the movement, hit the barrier, get close to the barrier where there's discomfort, but then come out of it. We're not trying to force it into that motion. I think a lot of times clinicians, can get into a problem where there's a need for increasing motion. So it's a ton of stress and pressure to push into those motions to gain access or, to stretch the tissue. And you don't necessarily need that. A lot of times when that inhibition there or that guarding and protecting is going on, and even if it's purely fear, just getting up to that boundary and backing off and building confidence in the ability that, hey, I can get to this point and it not cause pain, and do that over and over and over again. And a lot of times what you start to see is it starts to relax. The
Mm-hmm.
tissue starts to relax, the spasming starts to relax, the mentality that I can actually move close to that range and not cause pain starts to create confidence in the movement pattern. And you start to see a lot of improvements collectively of how the shoulder moves. Another tactic that I think is really effective is getting close to those pockets of motion and doing a lot of variety of isometrics in those positions at varying intensities and varying durations, depending on the type of tissue that I'm trying to attack. Because what happens a lot of times when we get close to those ranges that there's pain, the muscles don't really fire very well. Like the pattern is not very good because we haven't really worked there in a while. So I've had plenty of times where I would put somebody in a position that's relatively close to a painful position and have to ask them to contract, and everything else moves but what I want to actually contract, because they've learned these patterns of dysfunction to move around it so much that the body has almost forgot how to create the signal to the muscles needed to
Yeah.
move in those patterns. So it's also another way to build confidence that I can contract into this spot very close and feel the muscle contraction but not cause pain, or cause very, very little pain or minimal pain enough to where I can feel it. And it builds confidence to be able to move into that area. So using some of those two or three tactics, I've had a lot of success with, especially with those who've had chronic pain and hadn't been able to move their shoulder to a certain degree for a while, to regaining that pretty quickly.
I feel like that was maybe one of the harder, I've gotten a lot better at it, but harder things was communicating to people, giving them that license to be in pain. Hurt in this specific case may not equal harm.
Right.
You're going to be okay. And also just trying to get over that hump of, if you've got something that you want to be able to do and historically it's caused pain, we kind of have to do it at some
Yeah.
point. If you have a fear of dogs and you want to own a dog, well, there's no other way other than progressively introducing you to a dog. And we can start somewhere really comfortable, to your point. But at some point we got get a little uncomfortable. We don't want to
Right.
cause a panic attack, but having you sweat a little bit and then come back down and not have an anxiety attack, that might actually be a really good thing because you get to recover from that. So I think the skill is finding that line that you don't want to cross and getting right up to it and then backing off
Sure.
and then doing that, to your point, as much as they can take physically and psychologically, because those are just wins. Like every time.
Right.
So I love is when I do a session and if I call someone the next day, I'll tell them after, I expect you're going to be sore tomorrow. And I call them,
Yep.
are you sore? Like, yes. You turn it into a positive. We knew
Right.
it. We knew it. Good. That's exactly what we wanted to happen. You have tools to manage that soreness, right? Remember these stretches and different things. Do those today. And then they realize, oh yeah, that was the soreness and the pain was part of the process. We got what we expected, and I have the ability to manage that. So all of these things that could be negative and have been negative previously get to start being positive because there's agency there, and they expect it to a certain extent. You know what I mean? Like that, and I think what you're hitting on is just basically being a really good communicator. Not just being
It's
good at exercise and rehab and seeing the big picture, because we can sit here as clinicians and like we see the master plan, but if the patient doesn't understand that, then we might be looking at it like, oh man, this is going exactly how we want, but on the other side of it, they're thinking this is failing. This
right.
is not how it should be, and because they don't understand. So that ability to communicate, I think, for me, is one of the most challenging things. It's just, how do I? Because it has to change with every person.
Yeah.
I've got some young athletes who I feel like I could grind into the floor. They're just tough and they want to work back, and they absorb everything quickly. But I've got other athletes who are not like that.
Yeah.
Similar demographics, similar sports, you know what I mean? Or just they need something totally different. So you just can't approach everyone the same way, but you have to find a way to communicate the same information differently, regardless of the person.
Sure. And that's why every injury can be different, right? Because every person's different. Every person's going through different things. Mentalities are different. The connection to that injury is different mentality wise for each person. So I think you hit it spot on of the importance of the communication and going back to the team aspect of the plan. Like we're both involved in this process to get you better. So if I just went to a patient and said, "Hey, we're going to do this and it's going to hurt," like that probably wouldn't go over very well because there's no explanation of why we're doing something,
Yeah.
and how could we potentially use those symptoms as information to better prepare our program as we move forward.
Yeah.
And like I said, timing, that's one thing I really try to harp on with a lot of my patients is it's not just about feeling discomfort, but did you feel it during the session? Did you feel it an hour after? Did you feel it later that day? Did you feel it the next day, as you were mentioning with the soreness? The timing of when those things happen tells us as clinicians a lot of information to how did that tissue respond to what I prescribed to it, and then how do I make the adjustments as we move forward. So if the patient is armed with that information going into it, they trust that process a little bit more of like, okay, this isn't hurting just to hurt. Like there's actually information we get from this, and
Yeah.
I understand how we're going to use it. So it always goes much further when you can really explain the details of the why behind the programming and being very selective. And I think when you do that as a clinician, it builds confidence and trust. And it's like, okay, well, they actually are doing this for a reason. They're not just slapping a few exercises on a piece of paper. There's actually a process behind how they're trying to approach this. So it creates a little bit more buy-in, I believe, for the patient. More comfort that they're actually getting what they need. Because I've had times where I would explain that, and I would get a text from a patient the next day, and they're like, "Oh my God, my shoulder is really sore." And my initial thought was like, "Oh man." And then they'll follow it up with, "Oh yeah, but that's what we were expecting, so I'm going to do this, and I'll see you in a couple of days." So just really taking that positive silver lining approach to it. And I know you've seen this as a clinician. It's just, I think at the end of the day, from a mentality standpoint, you're trying to create as much of a positive outlook that we're trying to focus on what you can do as we get you back to your ultimate goal and performance, to keep that positive mindset on the approach of the process. When somebody has that positive mentality on the approach, the rehabs always seem to go well. Like
Yeah.
they're always better, right? Like when you can create that buy-in and that positivity that we're going to get to the place that we want. It always goes better, and it takes a little bit longer for some to get there, and rightfully so, especially those who've
Yeah.
had some chronic pain they've been dealing with for a long time. But yeah, that can be tricky.
Well, words have meaning. and the
Sure.
interpretation of those words dictates outcomes a lot of times. I mean, I'm sure you've seen it where the type of new patient who walks in with their phone with an MRI or an X-ray on their phone, and they identify with the findings and the way that was described to them. They may be looking at their spine and they're like, "Look, I have bone spurs, I have degenerative disc disease."
Yeah.
You know what I mean? There's all these scary terms, and I look at it and be like, yeah, technically, but I would have just described it as normal degenerative changes and moved
Right.
on. You know what I mean? So there's a big difference between, like, if you say someone has a bone spur, it's like, oh man, that's probably what's causing the pain, right? It's a sharp thing digging into the tissue, and I have degenerative disc disease. I have a disease in
Right.
my discs. And it's like, yeah, it sounds terrible. Hey, you look at it, you're like, nah, I mean, for your age, normal, that's probably 99% of the population. Yeah, you've got some decreased disc space, a little bit of changes there. You know what I mean? Like, it's is
Right.
whatever. Like, let's move on. It doesn't mean you can't. And you have back pain. You know what I mean? Like, let's good. We have information.
Sure.
Let's move on. But people get again. I think it's well meaning. Hopefully, when people use those words, although some of them I don't know why people do use them still, but or give those simple mechanistic explanations. Oh, you have pain. This imaging is clearly why. Now, there are certain instances if you've got hip pain and you do an X-ray and you have a shattered hip, I'm pretty
Right.
sure that's the problem. You know what I mean?
Right.
But for most people, if it's not trauma or some kind of crazy pathology, yeah, the imaging findings are probably a contributor for sure. But also, what are you going to do about it? We're not going to go in there and like reverse your arthritis.
Right.
That is what it is. So it's like we can do this whole thing of like, woe is me, and it's so bad, but ultimately we can't do a spine transplant. I guess you
Sure.
can do shoulder or different types of surgeries. But anyway, I guess my point is that, the way that people receive information and the words that are used have a huge impact. And I feel like a lot of times when people have been down a pipeline and then they come, at least to me, and then they have these words in their head, and now they've identified with this problem for a long time. They've been bone on bone for 10 years, and that's just their knee. I'm bone on bone. You know what I mean? Like, it is
Right.
their personality at that point. And it's frustrating, but I also like immediately feel bad for them, because it's like you're carrying around a weight that doesn't even exist. Like, it's not even a real
Right.
thing. And you've been carrying this burden and limiting movement. That's the other crazy thing. It's like, we know the benefits of routine physical activity. I don't think anyone can dispute,
Sure.
improving mood, improving sleep, decreasing your risk for heart disease and cancer and diabetes and dementia and Alzheimer's, and boosting your immune system, and all these great things, undeniable. So let's say someone has shoulder pain, and a well-meaning clinician says, well, we're going to do prolonged rest. And it's like, you're going to increase their risk for heart disease, diabetes, cancer, Alzheimer's, and dementia because they've got a rotator cuff problem. You know
Right.
what I mean? Like, that doesn't make any sense. Like, and people don't think about that. I don't think the clinicians are thinking that, like, oh, I'm gonna hurt this person. And I don't, obviously the patients don't see the bigger picture. But when people come to me and I'm sitting there thinking like, man, this advice, these words that were used, although they were well intentioned, have actually not only have they not helped you recover from this injury, but you are now objectively less healthy, and we have increased your risk for some of the most common chronic and fatal diseases that we see in America. And it's just like, I wonder when, as a healthcare community, we're going to stop, like, come together and be like, yeah, probably shouldn't explain things this way, or we probably shouldn't recommend prolonged rest other than in very specific instances. But I think it's just an easy thing to do if you're out of your depth and you're seeing, and because I've worked in clinics where I've seen like 30 to 50 people a day,
Yeah.
where that was the expectation. And so when you're in there for 5 to 10 minutes and you don't really know the person's name, and it's a Friday and it's your 30th patient, and you
Right.
got to be in at 6 a.m. on Saturday, I get it. The willingness and the energy to have this level of a conversation, even if they gave you time, it's just not there. But it's still kind of sad because, as I said, words have meaning, and people are going to make healthcare decisions based on the words that are used and their interpretation of those words. So the ability for someone to go see someone like you know, where someone you can take the time, you can make sure they understand. You understand that rehab to performance, not just rehab to get out of pain. You just get that full package. And I think going back to PT Biz, it's just, I feel like this is a community of people that I've now been able to link up with, that everyone just kind of thinks the same way, or is these, at
Right.
least maybe it doesn't even practice that way. Like there's a high standards to hit, but we're all kind of working in that direction. How do I refine my practice and my communication skills to be able to provide consistent outcomes for the people who have all these active goals? And it's a challenge. It's something that I wish was like, there was, we were able to have the ability to have more emphasis on these types of outcomes and everything that goes into the outcome when we go through school. And I don't know what kind of reform it would take for that, but I definitely didn't. And I think I had a good education, but it just was, it's eye opening when you realize everything it takes to get someone back to where they need to be, including the words that you use in the first in the first interaction with them. That could set the
Sure.
tone. So it's challenging.
It's hard, and I don't, there's a lot, there's a ton of layers to it, right?
Yeah.
Like as you mentioned, it's not just our profession, because yes, like you and I come from different schools, and our license may say the same different things, but we're ultimately doing the same thing. We're ultimately working to get people back, and using a lot of different treatment styles and modalities to get there. So I don't know. And I would agree, like some of the things that we're taught in school, and then you get out and you try to see some of the application. And I don't know if it's like a medical model versus a performance model mindset
Yeah.
that happens a lot of times where, you know, not to get into like any type of longevity talk, but, like a lot of the medical model is so focused on lifespan more than they are health span, right? Ultimately trying to keep somebody as healthy and moving as long as possible is more of the mindset that you and I take, and others that are, developing systems, like we are. And it becomes challenging. You mentioned the imaging piece. Like, I think imaging is great when used the appropriate way, but the problem with it a lot of times when it is being communicated to patients is it creates negative labels. And, that starts people down the wrong path. Is you have the person who at one point in their life had a bulging disc, and then anytime their back hurts, it's like, oh, it's that disc again. Well, probably not. It's probably not that. So let's, my approach has always been, let's focus on what you can do and not what you can't do.
Yeah.
And, because it's, yes, we're going to treat the symptoms and what's present. We're also going to work on a lot of other things that are going on that could potentially impact your long-term health and ability to move. And we're also going to maximize the things that you can do. There's so much focus, like you said, it's, there's a shoulder patient, so don't do anything. That's focusing on what you can't do. You can't do anything. You got to go rest because I'm thinking about this localized pain that you're having. But you're not taking advantage of all the other things that this person could potentially be doing that could impact their collective health and
Yeah.
well-being, like going for a walk, like doing other things. Maybe there are certain movements of the shoulder they can do. And when you say that they can't do anything, you're impacting their lifestyle. They're impacting things that they enjoy doing.
Yeah.
What if their shoulder symptoms have nothing to do with the things that they like doing? So now if you're telling them they have to be bedridden for a couple of days because of the shoulder, now you're taking away other factors that impact their mental capacity and potentially, keep them in a good place moving forward. So it has the focus has to stay around continuing to focus on maximizing the things that you can do and you should do. And then we'll fill the gaps with the areas that are limited, and we'll put together a plan to move forward with that, because there are, maybe small instances where something is a quick fix, but typically a lot of things take time to get better.
Mm-hmm.
So we can't just wait. We can't put life on pause or put our goals on pause because of waiting for something to get better. We have to be proactive, not only in the plan, but also proactive in our life and doing the things we enjoy doing around that as much as we can. And it's a fine line. You got to play that game a little bit of like, how much can I actually do without, causing more problems, but also maximize, the ability of what I can do. It's a tough balance, but that it still goes back to the team of the clinician and the patient. If you're
Yeah.
having conversations around that, you can find how to balance that. It just takes a lot of communication on both sides to get there.
Yeah. And I think, like, going into sticking with the shoulder theme, something that I feel like the words that get used and people don't really maybe understand is, like, I feel like a lot of people who come to me with shoulder pain, they've been diagnosed before with a rotator cuff problem,
Right.
and they don't know what the rotator cuff is. That, and someone may have tried to explain it to them, but I think a lot of times it was just a quick interaction. They understand that label, they've heard it before. It's kind of like tendonitis, and then they have a rotator cuff problem, and it's so common. And because of that, they can't do X, Y, and Z. They need to rest. These certain things are off limits, but they want to be able to do certain things. I would imagine that you see, well, I'm sure in baseball you saw a ton of rotator cuff issues, but just in the general
Mm-hmm.
population working with shoulders, you see a lot of rotator cuff stuff. Is there anything in general, like a big trend for those people out there who are like, yeah, they're listening up right now, like, yeah, I've got a rotator cuff problem?
Sure. Yeah. Going back to some of the points that we talked about before, like if you just look at the shoulder itself, and the rotator cuff is what it is. Like its primary job is to stabilize that shoulder joint, and it's a very problematic for a lot of people. And for various reasons, people have some issues within the rotator cuff. But again, how well does the shoulder rotate? Like the actual capacity of the shoulder to rotate, because similar to to some of the similar points we're making about things not moving or being afraid to move, if the shoulder is not rotating or not moving, you're not contracting the rotator cuff. So therefore, you have to run the risk of it getting weaker and atrophying, and not being able to use the tissue as well because you're not going through its full available motion. But I think it's important too with the rotator cuff is, because of the name rotator cuff, we only think about the ability to rotate the shoulder, or the contraction of the muscle rotates the shoulder, which it does, right?
Mm-hmm.
And there's a lot of exercises in isolation that can potentially isolate the rotator cuff. But we don't want to forget about the fact that its ultimate goal is to keep the ball in the socket for the most part. Like it creates a suction cup of stability around that ball in the socket to keep it stabilized. So that's not just a single muscle action that's happening there. That's kind of the whole rotator cuff working together. So adding in, or for one, if you're doing any type of upper body exercise, you're working the rotator cuff. Like, I mean, it is getting exercise during that time. But a lot of exercises that especially, you know, create distraction of the shoulder are things that I really enjoy and find a lot of success with, whether it's like a carrying exercise or a
Mm-hmm.
variation of like a hanging exercise where, because of gravity, it's kind of trying to pull the ball out of the socket and the rotator cuff has to work to keep stabilized. I think adding variety of that into your programming is really, really good. I've done it with, those who are not athletes. I've done it with athletes. I've found a lot of value
Yeah.
of keeping those consistently in the program, and not just thinking about in isolation of doing a rotation specific exercise for the rotator cuff.
Yeah.
But you do have to, going back to what point earlier of typically not addressing the shoulder until there's a problem. That often is the case,
Yeah.
where you could do something as simple as add 1 to 2 exercises into a program for the rotator cuff a few days a week, and you know a lot of the issues with the shoulder are probably going to be resolved. But we typically wait because they're not the flashy, not the sexy exercise. You're at the end, so I'm ready to be done. So people a lot of times skip them or just don't really know much about how to do them. But the good thing about, like I said, if you're adding some of those variety of different types of exercises on the shoulder, you're still working the rotator cuff and getting a lot of work there. Just make sure the capacity of the shoulder to rotate is still there.
A long time ago, I still have shoulder problems. I'm right-handed. I have right shoulder issues from, it was from an actual injury, but it just kind of carried on for years. And eventually I found a really good PT. This is before I went to grad school, and she was it was someone I went and I paid cash for, and she spent some time with me, and she'd been highly recommended. And she was like, so we did everything with the shoulder, and it was a lot of rotator cuff stuff, a lot of tendon work, but it was my right shoulder, and I had my left ACL done a number of years before that, and they took off part of my hamstring for it. So like that leg was never the same because of that hamstring graft. And she noticed, and she had worked with Major League Baseball players before part of her career, and she was like, I'd seen this in pictures before where they lack rotation of the hip,
Hmm.
and you got it on the other side, and I really tight on that side just because like the knee recovered really well, but the hamstring it was an issue for me all throughout college, and I like it's if you see me stretch on one side, I just never really regained the length or the strength, and I think it has
Right.
a part to do with incomplete rehab. But so part of my shoulder rehab where it was working on my hip,
Yep.
getting that range of motion back in the hip. And so I would say like 75% was working on the shoulder, but 25% was no, let's future proof this a little bit and get some movement back. So she was able to step back and look at the whole person, the whole system, and how
Hmm.
everything interacted, and was like, yeah, you can't get better to the goals that you want can't be hit unless we work on these other parts of your body. And I feel like at that time, not really knowing anything, her ability to communicate that well and take me beyond that label of, oh, you have a rotator cuff problem, and
Right.
saying, look, no, there's more to it than that. I find it really valuable, and I reflect on it a lot when I work with patients because I feel like had she not communicated it well, I wouldn't have been able to. I don't know. I probably wouldn't have stuck with the rehab quite so long, but I feel like when we're talking about rotator cuff stuff. It's something that's near and dear to my heart, just because I like working on shoulders as well, just because I've had a lot of shoulder issues. So it's fun to help people get the same results that I ultimately got. But how often do you see that where you're working on someone's shoulder and it's like, oh man, when we step back and we look at everything, there's other stuff going on, and we can't just hyper focus on this region here. We've got to look at other things. Is that something that
Yeah.
you see, especially where it made me think of it when you're talking about rotator cuff and baseball, because I was like, oh yeah, that at least that's how she had described it to me, that it was pretty common.
Sure. I mean, it's very common. I mean, and it becomes more movement specific or goal specific, I think, where you end up, or maybe the area that you end up focusing on that you're trying to address that could
Mm-hmm.
be contributing to a shoulder injury. I think it's, part of any complete evaluation when you're working with somebody is you're trying to kind of screen other parts of the area of the body that potentially have limitations or, limitations specifically that contribute to like activities that they typically do all the time, right? Like, because I mean, it's easy to single out athletes, but you can apply this to anybody. Is like with athletes, especially, is a lot of times the reason that they're so good is because they take advantage of asymmetries. Like this idea of perfect symmetry
Yeah.
is not really a real thing. Like sure, it can be a goal in your head, but the application of that's probably not very great. If you found a perfectly symmetrical athlete, they may not necessarily be the best athlete because a lot of times they leverage some of those asymmetries.
Yeah.
But you do have to identify when maybe some asymmetries are contributing to problems that they're having, right?
Yeah.
Whether it's performance or in this case pain. But I've seen especially in the baseball setting. I've seen it tons, and there's rarely a shoulder specific injury program that doesn't have something within, whether it's segmental spine work that we're doing, trunk control stability work, or hip mobility limitations that were found on examination that's also built into the program. It's
Yeah.
it's any program is very rarely just a single body part joint type program. We want to find other areas to address that could potentially be contributing to that. And that doesn't just apply to athletes, like we talked about a little bit earlier with, having some of the spinal mobility limitations. You see that in a lot of people. So there's very rarely a program for the shoulder, especially if it's somebody subacute or chronic, that I'm working on the shoulder, that I'm not addressing something um, within the spine, whether it's how it moves or how do you create trunk control.
Yeah.
I encompass the hips as part of the trunk myself when I think about it. So I rarely separate those two. I still think they all contribute in the same way. So there are times where I'm addressing hip mobility, whether it's pure motion itself or combined with strength. I mean, there's been times even with the shoulder I've addressed some ankle stuff with guys because there was a limited ankle mobility that was driving everything all the way up the full chain of the body. So
Yeah.
and then specifically with the movements that you're doing, whether you're training in the gym for some type of competition, if you're doing a ton of stuff on your feet, which most people do, there's a lot of energy transfer from the ground up, right?
Mhm.
And if there's a limitation or a gap somewhere within that system of transferring energy to the upper half, it puts more load and strain on the arm. So those are all reasons why, whether you're an athlete or not, um, that you would want to address, other areas of the body that could be contributing to the shoulder. It just helps you get to the answer faster. If there's
Mhm.
another part of the area that's putting stress on the shoulder and you're not addressing it, it's just going to slow down process. It's going to slow down your ability to get to the goals as quickly as possible. So you have to incorporate some of those areas. So it's good to hear that you worked with somebody who actually looked at that, because unfortunately, I don't think it is always the case. A lot of times it is just isolated focus on one area where the pain is and kind of chasing the pain and not really looking at what are some of the other contributing factors to the pain.
Well, I had gone down the pipeline of everything else failing at that
Yeah.
point. So it was a time I was back when I was in the Marines. And so you go to your battalion doc and they're just like, yeah, go to rehab. And then I basically would go hang out. I would see a PT for like 10 minutes and then it'd be some
Yeah.
PT assistant who would run me through stuff. And then as soon as I would, over a period of time, I would hit their range of motion and strength goals. They'd be like, okay, you're released. And it's like,
Right.
I'm still popping painkillers to sleep. So I don't know. And then they're like, yeah, but you can do everything you want to do. And it's like, well, yeah, because I don't really have the option to not, yeah, I'm
Right.
still doing pull ups and push ups and running around and doing all these things because it's just my job. And then you kind of go through that cycle a few times, start getting injections. And then it's like, okay, well, how many failed injections before we do something else? And it's like, oh, we have to
Yeah.
do 3. This has to fail 3 times before we have to repeat the mistake 3 times before we can.
Yeah.
So I just kind of went through that process for on and off for years. And it got to the point where I was just tired of it. And I just started looking for anything. And I was willing to, and keep in mind, like all my healthcare was free at that point.
Right.
But I was like, I don't care. I just started looking for, as I was, you name it, I tried it. I kind of got some results here and there. And then randomly I'd run into someone and was like, oh, you got to talk to this physical therapist. She's the best. And I was like, probably not, but whatever. You know what I mean? Like,
Sure.
I didn't go in there with any, actually, I don't think she had any benefit of placebo effect at that point. I was just like, yeah, I don't care. You know what I mean? I just want to stop taking painkillers every day. And it was just refreshing because she was like, what do you want to be able to do without pain? You
Yeah.
know what I mean? And sleep was one of them. So we spent a whole time like her working on sleep, like ways that I could comfortably lie down. And it was like I went to Target and bought a specific pillow to hug. You know what I mean?
Hmm.
It's not what you would think of as a PT session. So I could start getting better sleep. And then it was like, okay, well, I have pain with push-ups. Okay, get in push-up position. Let's work on some stuff. You know what I mean? Like, it was very much like, well, what's the goal? Okay, let's just jump right to that. And then
Right.
to your point, let's work backwards and see how far back do we have to go until it's moderately comfortable. Boom, starting point. Okay, now let's work back. And we just kind of, it's like painting a wall. You know what I mean? You got to keep going over it and over it. And you're going to move forward and
Yeah.
move backwards. And we just hit all these little things that I wanted to hit over time. And it would be like, okay, well, now you're going to go work on this. I want you to, this is the plan. You know, before I see you next, this is what we'll do next time if you meet these goals. And it was just, it was eye opening for me because I was like, oh, I, it's like, I've used this analogy on other podcasts before, but it's like if you have back pain and you go to a shoe store, what's the likelihood they're going to tell you you need new shoes? It's
Right.
to fix your back pain. The same back pain, you walk in a mattress store. Well, you must need a new mattress. You have it's hard because as the patient you have to pick.
Yep.
You know what I mean? Who is the right person? Who's the right profession? And then within that profession, who is the right subspecialty and who has the right personality? You have to make all of those choices with no information. And that blind choice is going to dictate the outcomes that you're either going to get or you're not going to like it's a lot on a person just to make those blind choices. And you can be like me where you just take years and you just spend a ton of money and a ton of time basically crossing things off a list, but a lot of people won't do that. And it's refreshing when you finally get in front of someone and that person is like, well, who are you and what do you want? You know what I mean? And they're
Right.
like, I don't have any plan. Like I have no expectations for this session. I don't have a rotator cuff plan. You know, we're
Right.
just going to look at what are you trying to accomplish? Well, where are you now? Okay, well, you know what I mean? Like, it's almost like a workshop where, for me, she was just like, I don't know, let's test it and see if you get better. And if you don't get better, it's just information and we try
Yeah.
something else. And we just, this process of test and retest and make a hypothesis, test the hypothesis, constantly checking in on my goals and not caring about my range of motion or you know what I mean? Like, I'm sure she
Right.
looked at those things, but I don't remember that ever being brought up as like, oh, now you're at 140 degrees of whatever. It's like, I don't care. You know, I didn't care.
Right.
It's like my thing is sleep and performance and I'm reducing painkiller intake. And that experience for me was eye opening. And I think it's just very positive. And that's why I feel like I hope that I can give that same experience to people. You know what I mean? I hope when they walk away
Right.
from my care that they're like, oh, that was more than what I thought I could get out of an interaction like that. Because have had that before. And I was like, it's so valuable. And even looking back at what she charged, I mean, it was a steal. I would have paid, if I had known the outcomes ahead of time,
Right.
I would have I would have paid her way more than that, and then she charged, and she wasn't cheap, but it was just for me it was what I needed. So I don't know.
And I think that's where, society's at. I think we're at a very interesting place where collectively people are starting to be more, the light bulbs turned on a little bit more about there being more variety in the way I approach my healthcare and my health span and more options. It's not as much of it specifically from an injury standpoint. It's not just, go to my PCP, they tell me who to go to, and I go there and I get treatment necessarily. There's people are being a little bit more proactive and knowing that there's variety. And now that, businesses like, yours and mine and others are starting to come up that are offering a different approach than what they're typically used to. I think it's going to continue to grow and people are going to see the value in it. And it takes time, because if all you know is the other option, you kind of just expect that everything is that way,
Yeah,
right? I remember, it's interesting hearing your story from being in the military because when I worked with the military, I heard very similar stories. And they would go to the hospital on base and they would, see a PT or somebody for the evaluation and then get handed a piece of paper and do most of their stuff, and which is why they were so appreciative with the model that I was able to work in, where it was kind of what we're talking about, where it's, hey, you come in and let's talk about what's going on and let's figure out the best course of action to get there,
yeah,
versus being, kind of constricted with access and the ability to do it. So being able to provide that for everybody, and I think that's always been my mentality of as I kind of transitioned out of pro sports is like, all right, I want to bring that environment to everybody because I see everybody as an athlete. Like, sure, there may be not like a specific high level skill involved of playing, at 7 o'clock on TV, but if you move and you express force in some capacity, you are an athlete. Like you should be approached and treated the same way. So, what is a model that has been applied at the highest level that's made the marginal changes that has moved, the best to, 1% change because when you get working with really, really high level bodies, it becomes harder to make improvements, right?
Yeah.
Like you see it all the time with those who compete at the highest level where, you know, zero point 0.1, zero point 0.2 seconds in the Olympics is the difference between a gold and silver, you know, so it takes a lot to make those adjustments. But the beauty of that is once you learn how to do that, you can scale that down to apply it to everybody. And a lot of times it just comes down to the approach. It comes in the proactive approach of being the teammate with the patient. You know, the communication that we talked about, and then the building backwards piece. You know, like you kind of laid out a great example with your experience with the physical therapist of the idea of working backwards from the ultimate plan. You know, it's very easy to fall in the trap as a clinician to, no matter how the patient presents, you know, I'm listening to the patient tell me what's going on, but I already know what I'm going to do with them whenever they're done talking, because they're coming with a shoulder injury, and we're going to start out with these exercises no matter what. We're going to start at ground zero because that's what you do with the shoulder. Whereas if you take the approach of building backwards, you really get a sense of what can they actually do right now. What's the things that can have the biggest impact on their short-term day-to-day life, and then let's build into some of the longer term goals to get them back to the performance. Because like you said, you didn't care about what your shoulder motion was. You didn't care if she told you it was what number it was. You cared about how it impacted your results, and she cared about those things more than
Yeah.
anything. And so that created buy-in for you. So you trusted her process because you could tell that she cared about the things that you cared about. And she wasn't trying to persuade you to care about other things. Not that, you know, not that clinicians will do that on purpose, but that's just kind of the mindset, you know, of changing some of
Yeah.
those numbers like we talked about. So yeah, being able to provide that experience to the masses of anybody who has goals that they're trying to get back to, that doesn't want to be in pain, that whether it's competition or just day-to-day life, I think it's needed. It's a hole in the healthcare system that needs to be filled. And luckily, there's a lot of clinicians like you and others who are trying to do that and provide those opportunities for people.
Yeah, I think it's a big yellow flag for anyone if you go to a healthcare provider, regardless of their profession or their specialty. If you feel like it doesn't matter what you say, you're going to get the same treatment.
Yeah,
That's, I say yellow flag because, you know, if you go in and you have a staph infection, not a lot of variability. You know what I mean? Like
sure, sure,
if you have a heart attack, you know what I mean? Like there are obviously extreme examples of where there is one appropriate way to handle something. But I think in the realm of conservative musculoskeletal care, aches and pains, there's so much variety. And I think most people don't read research, and they shouldn't because it's boring and it's
right,
hard to interpret. But, you know, if you look at, I think you look at a lot of like pain science research, you could say, well, everything works about as well as everything else. And I would say, no, everything's equally as useless as everything else. So we can kind of do, you know what I mean? Like if you love joint manipulation, you need to understand that it doesn't outperform basically anything else. And if you love soft tissue therapy, it doesn't necessarily outperform. So you don't have to have anything. But if you have a clinician who's actually listening to you and focusing on what you care about, and I remember early on when I started practicing, I was talking to a more experienced doctor, and I was like, you know, you you don't really ask a lot of questions when a new patient comes in. You know, what's that about? And he was like, I've been doing this for a long time. I heard everything, and that was kind of it. Period. Move on. And it was like coming right out of school. You know, I'm like, well, that's exactly what they told us not to do.
right,
You know, and so I remember thinking like, oh, this is a fork in the road, so I can latch onto that and celebrate it and be like, oh, I don't have to do that. That was just something to pass boards. Or I could kind of think about it and not emulate that, you know, or not
right.
repeat that. And I still remember that conversation, and I think he's a good guy. I still know him, but that is the type of care that is provided because there's that feeling that, you know, I've done this for a long time and I've seen this injury a million times, and I know what you're going to say, and I know exactly how I'm going to handle it. And statistically, maybe more times than not, it actually does work. But some of us don't
Sure.
fall into statistics, you know, and I can just tell you from experience, when you don't fall into that statistical category where you get better, it just gets frustrating and it gets dark sometimes because you just start to think like, what if this is just my life now? And it's just,
Right.
oh, it's a terrible spot to be in because then things don't really matter. It's like, well, I guess it doesn't matter if I do this and it doesn't matter if I do this, other things. And when stuff stops, when stuff that used to matter just doesn't matter anymore, you, then you just, it opens up Pandora's box and there's so many other things that can, can go wrong. And it's not too, I don't know. I don't want to be like trying to make this sound more devastating than it is, but you've seen it before where people, they can't do the things they love doing and interact with the community that they love, and it affects them. It doesn't just affect their longevity and their lifespan and their health span. It affects their social relationships and their stress and their, some people have issues with anxiety and depression, and community is a big thing. People start to lose that. And especially for athletes, if you get that athlete who's now injury prone and they feel like they carry that label and they feel like they're letting their teammates down and they might lose their scholarship or they might lose their contract. And there's a lot of emotional baggage that goes along with being away from sport or away from activity. And I think we've probably, if you've been an athlete, you know what that feels like. And it's just like, if you go to someone and they're not thinking about that and it's just a rotator cuff, here's the list of exercises, man, it's not a great place to be. And for people, I think a lot of times when people are like, well, do you think I shouldn't use my insurance then? And it's just like, you make the decision you want to make. And if you want to go try it and it works and you
Right.
fall into that statistical category where you end up getting what you want for a cheap copay, totally do that. I would do that. You know what I mean? So
Right.
I think you should, if you're curious, just go do the cheapest option, because sometimes shopping at Walmart is the right thing. But other times, if it doesn't work, you can't keep doing the same thing over and over again and hope for a different result. And I think
Right.
that's the pattern that people fall into. Well, it's like, I've had this pain for 10 to 20 years and this is what I do and it's not changing. And it's like, well, haven't you thought about doing something different? And it's hard not to be sarcastic but that's the thought that's going through my head. It's like, well, you're not a stupid person. And sometimes people just in a very kind way need to be presented with that, like, oh yeah, it doesn't make sense to keep doing the same thing because I haven't gotten the result. I have to do something different. And as soon as people
Mm-hmm.
can be open to that, then they ask the good questions. Well, what could we do? You know what I mean? Like, where's the
Right.
most bang for my buck? And it's like, oh, I'm glad you asked. You know what I mean? Because for some people, it's like, you need to work on your sleep, or like, you definitely need to talk about nutrition. You need to talk about exercise. You know what I mean? Like, there's so many factors to this. And the co-management piece, I think, is the most valuable. And I wonder, for you now practicing in a different state, has it been hard to make those connections with other healthcare providers to start to build that co-management team in your area because you're so used to having it?
Yeah, it has been. I mean, it's a new thing for me. Obviously, with the last two places I was at, it was just presented to me. It was there day one,
Yeah,
right? So having to go out and not just meet other healthcare professionals and practitioners in the area, but meet anybody. We moved here, we didn't know a single person. So it's kind of like it's a win-win for me in a way, in that I get to go out and meet people and expand my kind of circle of expertise and network with really smart people in the area that could potentially impact my patients, but also meet people and have great conversations with like-minded people, because that's what
yeah,
I enjoy doing. I love, you know, talking about complex and difficult topics and beating them up and trying to get different
yeah,
perspectives from different people, because it's fun. It's fun to do because you always take something out of it no matter
yeah,
what. So that has, that's an important piece for me, is especially after the experience I've had. It's like I feel like I want and need to have a lot of smart people around me that have different perspectives. If I really want to impact my patients in the best way possible, it's being able to lean on others that are really, really intelligent and could potentially impact the plan of care. Whether it's from a nutrition standpoint, sleep standpoint, mentality standpoint.
yeah.
meeting good physicians. It's not like the physicians are completely bad. Like, they do a lot of good, and they're a very primary portion of most people's plans of care overall. So they need to be included in that process. But picking their brains and actually get them actively involved in that plan for people can really go a long way. I mean, I've had plenty of patients in the past where focusing on some of those areas outside of the treatment room, where it's having conversations about sleep, it's changing things within their nutrition plan, ends up having a significant positive impact on their rehab.
Yeah.
And it makes my life easier. It makes my job easier from a programming standpoint, because I know some of those other barriers that could be hindering them getting back to where they need has already been they're being fulfilled. Whether it's from my own guidance or another clinician that I've been able to bring in.
Right.
We've done the same thing like on the sports side. With different chiropractic physicians that we've worked with, and it again goes back to the person, right? Like, if the patient really buys into certain things, you have to consider those thoughts and implement those things in. If they're very nutrition focused, you have to gear that towards their plan of care and implement in their plan of care as much as you can.
Yeah.
So it has been. I mean, I've only been out here a few months, but I've met a lot of really good people, a lot of intelligent people, to kind of build within that inner circle of a network of clinicians to work with. And the goal is just to continue to expanding that, because every patient needs different things,
Yeah.
and you want to have a large library of access to different people, because you never know who's going to be able to help the next patient. So it's continuing to build that as much as possible and learn from them in the process too.
Yeah. Yeah. I love referrals from physicians. I'm starting to get more and more just as I build those relationships. But man, that is the buy-in from the patient is so big when, the primary care physician is, hey, you need this. This is who you should
Yeah.
contact. And then they contact me, and then and I go, okay, well, I'm going to call your doctor and get the down low. You know what I mean? I'm going to get, and then they come in and see me like, I've already talked to your doctor. You know what I mean? You tell me the
Yeah.
story and I'm going to match this up. And then it's like after the visit, it's like, okay, I'm going to shoot her a text, or I'm going to call her later this weekend, or I'll fax over my notes. So then from the patient's perspective, it's like, oh man, I've got two people collaborating on my behalf. And when we're both generally in agreement, and we're both following up, or, you know what I mean? There's just like the ability to collaborate. Not only does it make the care better, it makes my job easier, but from the patient's perspective, I feel like they're just so much more invested, because there's that social proof. It's like
Yep.
it's not just one person's opinion. I've got two people who are very well educated and experienced shaking hands and saying, "Yep, this is the best thing." And
Right.
usually patients are like, even if they don't want to do it, you know what I mean? Like, nutrition's a good example. That's a hard sell,
Yeah.
because it's like basically what someone hears is, I want to know what you do when no one's looking late at night. You know what I mean?
Right.
I want to
Yeah.
judge you for what you feed your kids, and I'm going to judge your parents for what they feed you. You know what I mean? Like, the people don't want to talk about that stuff.
Yeah.
But I feel like, if you got a couple healthcare providers being like, "Hey, I think based on everything, I think this is something we need to tackle." You know,
Right.
people are like, "Okay, well," they kind of let their guard down a little bit, and I think it's that way with like depression and anxiety and stuff like that, where it's like, "Hey, I think it's not my specialty, but I think this is affecting you." And
Sure.
it's something we got to get. Like, I can't help you with it, but I know people who can. And if you have a primary care physician who says the same thing, like, yeah, I think this is a good idea, and we both recommend a list of people, and they're like, okay, well, this is probably something I should do. The likelihood that they're going to make that appointment, and then if you can, the likelihood goes up, and then if you can get that provider involved, you know what I mean? Like, and when you do, let me know. I'm going to fax them something. I'm going to call
Right.
on your behalf. I just, within the last 3 years, I think I've done a pretty good job of starting to build that network. And now I'm starting to see it pay off a lot, where people really value it. And then those tend to be really good patients, because They stick with the program. There's a lot of buy-in. I have a great time. You know, they're
Yeah,
just they're really happy to be there, which is different than other scenarios where the patient doesn't have any buy-in. They're not happy to be there. They're just kind of they're not fully invested, because it's hard to be fully invested if the patient's not fully invested. For me, anyway, I just
sure.
it's hard for me. It's hard for me to go and give 110% when I feel like I'm getting less than 50%. You know what I mean? Like
Yeah.
I think it's just human nature. It's hard to bring it every day when the patient doesn't bring it, and then it's a weird dynamic.
Yeah, I always make a joke with my patients, early on, especially ones that don't know me. It's like all I ask is that you match my commitment to you and your plan, because what they don't know is there's going to be a lot coming at them from that. So it's
Yeah,
going to be a big expectation to be proactive and be bought in. But the buy-in matters, man. Like we
yeah,
talked about, it's
it does.
it's the positive mentality that there's a real approach that I can have success with. I mean, I've had patients in the past, some of the best ones that really had success, especially with like chronic patients, is when you start to hear things like, I feel like this is really going to work even before they're out of pain, that there's a very good understanding of the plan and how we're going to get to the goals. But then there's that collective buy-in and some positivity that, although I'm not completely out of, I'm not asymptomatic at this point, but I can understand where we're going with this, and I really
Mm,
understand it. I think that goes a long way. And then the piece with the physician, you talk about like going through the conventional system of care. Like you're rarely getting clinicians in general that are calling another clinician on a patient's behalf, right? Unless it's a pure just the secretary's referring you over with a referral. But if you get a patient, and they're like, oh my God, my physician actually called the PT and talked to him about that. Like he actually cares about me getting better.
yeah,
My chiropractor called the physician and asked about some of my medical stuff. Like he actually cares about getting better. Now, I'm going to buy in. I'm going to care more because he's putting a lot of work and effort in getting me back. So I want to buy in more. So I think
yeah,
it's a circle of that, I mean, it goes back to that team approach of why it's so strong, like why that process is so strong when you get that collective buy-in. It's like the 1 + 1 = 3, like the synergy piece, right? Like if you and I are working together and I see you working hard, it's going to energize me to work harder, and then you're going to see me working harder, and it's going to make you work harder. It's the
yeah,
same approach with the patient, and then you add 2, 3, 4 clinicians into the mix, and everybody's really bought in, and everybody can see that everybody's working towards one collective goal. And man, that's a very powerful system to move things forward.
yeah. And the one physician I'm primarily talking about, we go to CrossFit together, so
Yeah, that helps.
we don't talk about patients at the gym, but
Yeah, yeah,
we text. You know what I mean? So like,
sure.
well, and I was just telling my patient like, I'm not going to text your name because I don't send patient information, but I'm going to be like, you know who I'm talking about. You know what I mean? So
Right.
it's like, if you're not doing there's just like, we can joke about it and they understand. And especially if we have another patient that also sees us both at CrossFit,
Yeah.
standing there talking like, you talking about me? Like, no, we don't talk about you guys in public. But I think those relationships, they help so much, and
Yeah.
it makes it fun. And I feel like I don't have to, oh, man, it's like this burden gets lifted. I don't have, since it's a team, I don't have to hit a home run every time.
Yeah.
I can fail and ask for help, and I know exactly who to ask. You know what I mean? It's like, and I've done that before where I've had people come in and be like, who's your primary care physician? Oh, good. I know her. I'm not 100% sure. When we leave, book an appointment. I'm going to call her cell phone and leave her a voicemail and tell her to expect to see you. And then I'm going to fax over a referral letter. Like, I'll do that right now, because I don't want to sit there and pretend like I know what I'm doing and just hope for the best, And I
Right.
think that happens a lot where it's like,
Yeah.
we're not really trained to be honest that we don't know. Like, we always have to
Yeah.
have an answer. And one of the things that I've enjoyed the most about, I think, maturing into this profession a little bit is I say I don't know a lot more than what people would expect. And I think when I
Hmm.
say it, sometimes people are like, "Are you like, shouldn't you know?" And it's like, "Well, do you want me to lie to you?" Like, I don't know. I'm going to try and figure this out, but I don't know. So this is my hypothesis right now.
Right.
And if this doesn't work, like if we're going to try this plan and we should see results, we should see some type of meaningful change within 7 to 10 days. This is what I expect. if you stick to this plan. So that's your part of the thing. And then I'm gonna tell you, if we don't see those changes, we're gonna shift and we're gonna go to this. You know what I mean? And then is that okay with you, or do you
Hmm.
want to do something else? And I think it's I've been met with a little bit of shock when I say I don't know, but most of the time they're like, oh yeah, well that sounds logical, because then they
Right.
realize that, like, oh, this isn't set in stone, and if maybe we have to get it wrong 2 or 3 times before we can find the right answer. Maybe that's the inevitable path. And sometimes that, for me, that path, it's not very much, but it's like 2 to 3% of the time, I'm making a phone call or making a referral, or I need help with something a little bit more complicated, or there's something else going on. They come in with a shoulder problem, but I have other concerns.
Yeah.
You know what I mean? And so I'm going to make a call on their behalf. It just gets easier once you start to have people's personal cell phone numbers, and you know what I mean? You can
Yeah.
call a physician and be like, hey, I'm out of my element here. What do you think? Would you see that? Can I send them to you? It helps a lot.
I think it's a big piece. I think it's, part of just the experience of growing as a clinician, like you said, maturing as a clinician, getting more secure with what you know and what you don't. Because early on, you're trying to feel like you got to prove yourself, and you got to recite everything that you just learned in school to the patient to show that you're knowledgeable. And I think
Yeah.
it's a common kind of progression you see over time. And then you really start to get more secure with what you understand, and you start to really desire to learn more. And
Mm-hmm.
the best way to know where to learn is you can self-reflect on the areas that you don't know as much, and you try to either fill the gap yourself, or get really smart people around you that can help expedite that process, whether they're
Yeah.
teaching you, or you're you know sending your patient to them to get additional information, or bouncing ideas off of them. I think that's the other beauty of having like a small network that you can work with, is you can call another clinician and be like, hey man, what do you got on this? Like, I cannot figure this out. It's just not making sense to me. And just having a different perspective sometimes can make you think of something different. And I think the beauty that we have in the setting that we're in, because we have so much more ability and autonomy as a clinician, is patients always are going to want to know, like, the answer. Like you said, you do an evaluation. Unfortunately, labels, I think, are more negative than positive a lot of times. But they're expecting kind of you do your evaluation, and then you splat a label on them. This is what you have. This is your
Yeah.
problem. This is the name of the issue you have going on. Well, to your point, sometimes it may not be that clear, because there could be multiple things going on, and you're trying to decipher which one is the primary,
Yeah.
secondary, tertiary issue. Well, the beauty that we have in our setting is we can say, well, our main focus is to impact the limitations and impairments that you have first. And chances are the true quote unquote diagnosis is going to flush itself out as we work on those things. But no matter if I give you this label or that label, that's not going to change your shoulder not moving. So let's work on the qualities that may impact your shoulder moving. And then as we go, we'll learn it. We'll get more information as we go. I think it was a hard lesson I had to learn early in baseball, specifically because, interesting in that setting, especially when I was treating as a treating clinician, it wasn't like one-on-one with every patient. Like, it was a true training room feel, where at times you would have a lot of players in that you were having to work with. So it was my first experience doing an evaluation on somebody where I had to break up that evaluation over multiple sessions, because I didn't have time. I didn't have a full hour to spend one-on-one with the player. I had to do the most important things in like a 20-minute window.
Yeah.
And then the next day when they came in, I would do some other tests. And honestly, I found that to be a very effective approach to the evaluation process, because I wasn't being rushed, right? Like, to just fit in all these different things, not really paying attention to them, just so I could give somebody this label or title. It's like, let's focus on some really focused stuff today, so I can evaluate, but I can also give you some treatment within that first session, and let's see how you respond, and then we'll evaluate some more things as we go. Almost every session, there's some component of reevaluation or evaluation going on, not just in your presentation, but it could be in another body part area that we're trying to look
Yeah.
at. So that's one good thing about, I think, in our setting that we're working in now, is we have the ability to do that, and really dive deeper. with a more thorough evaluation versus trying to really squeeze everything into this one short session, and then the person doesn't get any treatment, which is why they came here a lot of times, is because they're in pain and they want to have some type of relief.
Yeah.
And that works really well with those who come in that are not in pain. I see some that come in purely because there's some movement deficiencies or some strength imbalances that's impacting movement. And we can spread some of that assessment over time, to really get more of a large scope of the entire body and entire movement process itself. But within session to session, really have a focus and intention about what we're trying to accomplish every time they come through the door.
Yeah. Well, I have kept you for almost 2 hours. Time kind of flew by pretty quickly.
Yeah,
I'm gonna.
that's the thing. You have good conversation, man. You can just go
Yeah.
forever. So
Yeah, that's why I like the podcast. Has been fun because
yeah,
it gives me an excuse to just invite interesting people on and have conversations and learn stuff. And it was originally my wife's idea because I got invited on a podcast and I was like, oh, that wasn't a bad experience. I wish I could go on more. And she was like, why don't you just start your own? I was like, oh, yeah, that's a good idea. So
yeah.
that's where it came from. But it was a pleasure to meet you and a pleasure to have you on. And maybe we can do this again at some
Yeah,
point.
definitely for sure. I appreciate you having me on. This has been great. Like I said, this is one of my favorite things to do, is just have conversations with intelligent people and like-minded. And there's so much stuff to figure out still, right? Like I've learned a lot from our conversation. There's a lot to learn to help our patients, and I think all of us collectively working together is going to impact positively everybody that walks through our door. So definitely appreciate you having me on.
Well, the reason behind the podcast is to challenge and guide people so that they can reach full potential. So as part of that, I think it's what I would like to do in the future with this, with clinicians, is bring people on to break down a specific issue. You know, starting like what would and even if it's a fake patient, and it's just like, well, what would the history taking process look like? What would
Right,
the exam look like? And not from like a clinician standpoint, like you're teaching other clinicians, but as from a patient's perspective, what would really good care for this look like, and what might, you know what I mean, and kind of walk through maybe even just the more broad rehab and return to sport or return to activity processes, and then so people could say, okay, well, I have that issue, that's not what I'm getting, or I have that issue and I'm thinking about going to a healthcare provider. Okay, now I have a framework for making a selection, so they could go in and ask informed questions, and then someone could say, well, this is what it looks like, and they could go, oh, okay, well, that's not what I'm looking for, thank you very much, and move on to something else, or have a ton of confidence, oh, that very well aligns with what I think is what I need. You know what I mean?
right.
Because I feel like a lot of times, as we talked about before, people make these decisions with, I don't know, either it's someone recommended someone, or they got on the internet and it's someone close to them, or someone had a cool website, or
Sure.
they like their Instagram. So they're just making decisions based off of, it's like going and buying a bag of chips. You know, probably going to buy something at eye level that has a good logo, or you know what I mean? Like
Right,
you're not
right.
necessarily doing any research on what chips to buy. And I think, unfortunately, that's where people, for musculoskeletal stuff, that's kind of how they make decisions a lot of times. It's
Yeah,
like, I don't know if it's close to me, and they take my insurance, so I guess that's where I would
sure.
go. And so if you'd like to be back on to talk about something, even a patient case that you've had, I think that would be something I want to set up in the future with other clinicians.
Sure. I would love to do that. It'd be great. I think it's a
Cool.
great idea because it also gives, potentially two different perspectives on the process too, right?
Yeah.
So, anyone listening in that's trying to get a little information, they're getting perspective from multiple clinicians and from different lenses and perspectives. And I think that there's a lot of value in that. Like you said, it maybe broadens the idea of there's a lot of other chips on the shelf, right? Other than just that one in your face. So
Yeah. Cool. Well, it was good to meet you. Thanks for
appreciate it, man,
joining us.
for sure.